All right, well, we're going to go ahead and get started. Our next presenter is Susan Imke. She is a family and gerontological nurse practitioner. She is also a community health educator. Susan practices as a nurse practitioner with the Texas Healthcare and is president of Senior Health Solutions in Fort Worth, Texas. She's a faculty member of the Allied Team Training Program of the National Parkinson Foundation in Miami, Florida, and serves on the board of directors for the Parkinson Alliance in New Jersey. Susan has been a frontline family caregiver for many years and has authored a number of publications for families living with movement disorders and dementia. She travels across the country sharing her expertise with audiences like us today. Susan participated in one of our annual conferences. We were trying to figure out when, but we have determined it's been at least 10 years ago, back in Virginia Beach, and we are thrilled to have her back with us in Virginia. So please welcome Susan Imke.
Good morning, everybody. It's fun to be here. I would go nearly anywhere to listen to Fred Woot talk, and enjoyed that this morning. I didn't pick up from our last two speakers that these lights were difficult, but now that I'm on this side of the table, I feel a little bit like a prisoner of war, you know, in one of those interrogation rooms. So if I'm squinting at you, please don't take it personally. I came an extra day because I love this part of the country, so I came a day early to act like a tourist. And I've become acutely aware of two things in this part of Virginia. One is that people are just very nice. They are so friendly. There was a man panhandling, we would call it at home, down near the Shockoe district, and he actually asked me what my plans were for the day and was I enjoying my visit. And, I was going on the little river cruise yesterday, the canal cruise, or I had planned to, so I parked in a parking garage nearby. And then the cruise didn't go. If you remember, if you live in this area, yesterday about 1 o'clock, it started to rain again. So they canceled it and apologized profusely and gave me my money back. And when I told the car attendant this little story, she said, "Oh, I can't take your money. That would just be awful." So a formal garage gave me my $3 an hour parking money back. I want to move here, you know. I love being part of a program where this much focus is on exercise. You have the research thing, then after lunch we'll get very pragmatic with it, and I'm just looking forward to that presentation, and it's fun to be part of that kind of day. I am convinced after 25 years of working in movement disorders that exercise and movement matters as much as anything else. Although I did feel a little self-conscious that in terms of my preaching, my practice, you know, living up to my preaching, that I'm probably still classified as something of a couch monkey. So there we go. So we're going to talk today in my segment with you about what happens, some of the dynamics that happens in families who are living with Parkinson's disease, the caregiving choices and challenges. We may not can make you as young and beautiful as you used to be, or as some of you still think you are. You know, but we've made huge advances in neurology in terms of treating the motor parts of the disorder, and I thought it was fun to hear some of that this morning. Let's just talk for a minute together and admit out loud some of the things that life can dish out to us. Jobs end, spouses leave, relationships drift apart, health can deteriorate, people die, don't they? Financial security becomes threatened. How many of you feel as good about your financial profiles now as you did 5 years ago? If both of you would see me afterwards, I'd like to know how you did that. Yeah. Independence can be compromised, and none of us like that. Summation, no matter what the oil of Olay regenerist people told you, 60 is not the new 40, whether you've got Parkinson's disease or not. What are some of the challenges that are unique to Parkinson's? He used the analogy this morning of diabetes, you know, but compared, if I have diabetic problems or I have a heart problem, you don't know that unless I decide to tell you. You know, but with Parkinson's, there are some unique challenges. The symptoms are visible and can be erratic. On-off fluctuations can complicate your schedule planning. at these kind of conferences. I've noticed there's always a lot of last-minute add-ons and cancellations because the person with Parkinson's disease doesn't know if they can get the body factory to run when it's time to go to the meeting or not. So those fluctuations are difficult. The public can misinterpret what Parkinson's symptoms are. I have had many Parkinson patients who were in situations where someone thought they were inebriated. And in at least one case that was also true, but usually, you know, it's the levodopa wonders. The prognosis is uncertain in early years. When we share the diagnosis with a patient and a family member, they kind of want to know what to expect, and the truth is you can't tell them too much until you've watched how it progresses in those early years. Parkinson's disease that creeps along initially mercifully doesn't usually start to gallop later, so that's a prognosis factor. The individual response to medication varies pretty widely, and the rate of progression is not predictable. It varies from one person to another, and so those are lessons that people learn in the first few years. We think of Parkinson's as being a motor disorder, but sometimes, and if you can't see my slides, particularly those of you on the periphery to this side of the room, you might scoot your chair around a little bit. The slides are cuter than I am, and from the back of the room, they're hard to see. But this is what I thought was going to happen when Medicare first started approving the motors in those lift chairs. You know, I really foresaw a lot of disasters there that actually have not come to pass. In caregiving circles, Parkinson's disease presents a privacy challenge. I talk with patients every week who took that biblical adage of the two becoming one flesh just a little too seriously. I had a patient not long ago that it was new to me, and I asked him how long he'd had Parkinson's disease, and his wife said, "We've had it 11 years. And I said, "Really? It's been a long time since I had a husband and a wife where both of them had Parkinson's disease," you know. But it's very much a we kind of thing. I love the AARP caption that the wife is bemoaning to a friend that she married him for better or worse, but not for lunch. Hands-on caregiving can distort couple intimacy. That is a recurring issue as the disease advances, and one that's sometimes very difficult for caregivers and for the people with Parkinson's disease. Communication issues often get to be a big problem. I blame this more on marriage than movement disorders. Can you see the slide here? The little kitten says mew, and the bull says moo, and whatever, you know. So those things can be very difficult. Have you ever noticed that men and women use different words to describe the very same thing? My husband is a little older than I am, and he's a retired accountant. Frank's midlife crisis was to quit sleeping in a tie. So, you know, pretty conservative kind of guy. He's kind of my straight man. I love him a lot. But one morning we were at the breakfast table. He was reading from the Wall Street Journal. And he said, "Listen to this." He said, "It says here that women have to use twice as many words to describe the same thing as men do." Now, you know, I said I love him. I wanted to give him this one, but we've been married a long time and I couldn't. I said, "That's because we have to tell you everything twice." You know. So let's talk about some of the communication style. Yeah, so you people know that's true, don't you? Here's one of my favorites, the communication style of the controller. The credo of this person is, "I am not bossy, I just have better ideas." Or the peacemaker. All of you know someone in your family who's to pull everyone together. Why can't everybody just be nice? The negotiator, and my people I work with tell me that this is my style. I just cut a deal that I'll try to be nicer if you'll try to be smarter, you know? Yeah. Passive aggressor, those are the whatever people. If you don't know what passive aggressive looks like, just hang out with somebody in junior high or middle school, you know, and it's when they roll their eyes back in their head, that's that one. It's not the prettiest one. Let's talk about some of the elements of nonverbal communication. Your facial expression, and doesn't Parkinson's mess with that one? You know, where you've got the masked faces, the grandchildren think you're mad at them, and really you just are a quart low on levodopa at the time. Tone of voice matters. Again, an issue with Parkinson's. If you're in a serious, communication with your spouse or another loved one or a paid caregiving situation, they're having trouble understanding you, and you think you already are speaking up. So the speech language people do a nice job of helping with that in the Think Loud communities. Gestures, eye contact. We're really bad about having conversations from another room. Well, between a Parkinson voice and a spouse's hearing problem, that's never going to work, so you kind of have to meet in the middle somewhere. Spatial arrangements to sit facing each other. That's why people will share very intimate things riding in the car because they don't have to look at each other. I call it the by-the-way conversations, where you're taking the grandchild back to the airport, you've had her for 5 days, and half a mile from the entrance, she says, "Oh, by the way, Grandma, they're getting a divorce." It's those important conversations that happen in the car, but they're risky at best. Patterns of touch, expressive movement, all of these things matter in the communication efforts between people who are caregiving and their loved ones who have Parkinson's disease. So intentional conversation. You have to sit face to face, minimize the distractions, turn off the tube, and I'll say a little bit more about that in a bit later. Pay attention, try not to let your mind wander, respond appropriately, and this is the hardest of all. Wait for the other person to finish speaking before you jump in. Mind reading is a phenomenal problem in families, trying to finish the sentence, and no matter how good you are, it doesn't usually work well. It just is disrespectful to the other person. It's also hard to avoid telling the speaker how you handled the same situation. And that's best not to do, to keep an open mind and to practice. Because it takes a lot of intentional practice. These things don't get better just because you've been together more and more years. I want to talk about the challenges presented by the non-motor things, some of the mood disorders. Clinical depression occurs in more than 50% of people with Parkinson's disease sometime over the course of their illness. That is low mood for greater than 2 weeks before we consider pharmacotherapy, and I'll come back to that. Counseling and antidepressant medication is generally better than just antidepressant medication alone. I want to talk about anxiety because it is so common in Parkinson's disease. The technical probably more so than depression. The technical definition for free-floating anxiety is it manifests as brooding, excessive worrying, fidgeting, sleep disturbances, and agitation, and SOB. Now, that does not have to do with your character or your mother's lineage. It has to do, that's the medical acronym for shortness of breath. But if you think about it, some of those things are also just part of the dopaminergic problem. So we have to be careful to know what's anxiety, and we watch it longer over time for a period of few months before you start people on anxiolytic medications, because they can be kind of a double-edged sword. So if you have a problem, dopamine doesn't work in a vacuum as a neurotransmitter in the brain. It's all tangled up with acetylcholine, with serotonin, with the other transmitters. And so if you have a problem that's chemistry-based in your brain, it many times demands more than paint and polish, or just turning over a new leaf, or trying harder, or taking an extra Cinnamate before your tea time. You really have to know that they're very good medications. Here the little boy is saying, can my mother borrow a cup of Prozac? Yeah. And if you need medication to treat depression, you need that for a minimum of 6 to 12 months, more often in the 12-month range. You may not need it for life, like you will need likely your anti-Parkinson medications, but that's kind of the standard, is a minimum of 6 to 12 months. And a lot of times people don't acknowledge or know they're depressed until they start on the medicine, and then they'll say, wow, doc, I'm less argumentative, I'm sleeping less during the day, my spirits are better, I feel like going out to wherever that they, their prior activities that they've done. So sometimes the antidepressant medications help a little bit with the thing called apathy. Depression is also a problem for caregivers. Here he says, I'm depressed today, and if you really loved me, you'd have the decency to feel depressed too. So maybe it's a viral issue, and that's been overlooked, that you can catch depression, I want to talk some about dementia, what happens when the cognitive issues get larger over time. Dementia is gradual onset. It's never abrupt. The family who comes in to see you and says, Dad has been pretty good mentally ever since he's had Parkinson's, but he just went totally bonkers on Thursday. Dementia does not roll in on a Thursday. So in that case, it's probably some kind of delirium that's a response to an underlying urinary tract infection or respiratory crud is crud a word in Virginia? That hasn't been diagnosed yet, or it is something going on there, a medication side effect. Many of the Parkinson medications can cause delirious episodes. So it's defined by memory deficit plus one other cognitive problem. Early signs can include lack of abstract thinking. You know how you can tell a joke in little kids that are really smart, but they're 3, 4, 5 years old, it just goes right over their head. The same thing is true with early and mid-stage dementia. For instance, if I ask one of you, and somebody up here at front, you all answer this, what does it mean, the old saying of don't put all your eggs in one basket? What does that mean? Don't put all your hopes. It's like a poem, ma'am. That's what. Don't put all your hopes in one container that may fall and drop and break them all. I'm not sure I quoted you right. That's marginal. I mean, let's do it as a one-word response would be diversify. You know, okay. Somebody who's having the kind of abstract thinking problem I'm describing to you might say, "Well, the shells would crack." You know, it's a very literal interpretation coming back, and yours was actually fine, despite my torturing you. Yeah. It shortens life expectancy when dementia is a factor, so we pay very close attention to it. What about if you're the person living with someone who is sort of 2 tacos short of a combination plate? Then all of the adjustment is on our parts. The person with Parkinson's who has dementia is doing the best they can in general. Just because you become demented doesn't keep you from being the same manipulative individual you've always been. But in general, they are doing the best we can, and the adjustment factor is up to the rest of us. What causes this? Well, sometimes it's the medications. The very thing we're giving patients to help them move more fluidly can create havoc with their thinking. Sometimes it's depression. Depression manifests many times as cognitive issues. It may just be part of their flavor of Parkinson's disease, unfortunately. And then just the fact that you have Parkinson's does not guarantee that you can't develop some concomitant condition, a multi-infarct, a stroke-related dementia, or even Alzheimer's, which those are messy, messy combinations. So I want to talk about behavioral things that those of us in the driver's seat to facilitate communication with someone with some cognitive issues can do. First of all, simplify how you talk. You say, would you like chicken or beef for dinner? Not run every menu across your screen that's ever come up out of say, or would you like to go out, or maybe I could call Carolyn and see if they want to go with us. You know, you simplify, you want the red shirt or the blue shirt, so that you let people respond to pretty clear inquiries and directions as well. I'm going to skip the next one. Reinforce desired behaviors every time. Anticipate physical needs. Music in the routine is a wonderful way to relate to somebody. People will remember the old songs from their past long after their short-term memory is kind of shot in other regards. And so music, whether it's has words or music without words, just the rhythm and the melody is powerful. And then we'll talk about modifying the environment, but I want to go back to do not argue. And I'll be very serious for a minute. If you get into a verbal debate, argument, fray with someone who has even moderate cognitive loss, both of you will be equally upset when the argument's going on. But the person with dementia will be settled back down and may indeed forget that the encounter happened in about 2 hours. And 2 days later, you'll still be saying, how on earth did I let that happen? You know, so you really have to train yourself, and it goes against everything we think and know about marriage, doesn't it? But nevertheless, you have to learn a new trick while you're young enough to do that. I want to talk about environmental things. Look at the carpet around this room. If your levodopa or your dopaminergic medications are causing you to have some visual hallucinations, this carpet's a nightmare. You know, you have one beer and just squint a little bit, and it looks like that the planets are coming to get you there. So, and I'll show you some other examples of that. But there are things in our homes and the institutions some of you work in that we could do to sort of calm those things. This picture, the complaint was a woman named Annie who was coming up to the nurse's station in the foreground to get her medications, and then going back to her room about 2/3 way down the hall, she was hopping back and forth instead of holding onto the handrail. And I was working with an environmental design specialist, and Joanne Schroyer and I went to talk to these people, et cetera. And they were, of course, afraid she was going to fall. Matter of fact, she had fallen a couple of times. And can you tell what might be going on there as you look at that slide, those of you who can see it well? Stepping over a puddle, absolutely. See, we didn't have the luxury of this slide at the time to see the mirage type, the glare on the floor. And guess how we figured that out? We asked Annie. I mean, they paid us a lot of money for this. The housekeeper could have taken care of that one for them. And now this is a huge example of what's called visual noise. This woman's sister had decorated her room in the nursing care facility. I can only hope for Halloween. And she went totally nuts about a day and a half later, as I do just looking at the slide. This is an old slide, but it reminds me to say a word about television. Television is not reassuring to people with dementia. You remember when Laura Bush said after 9/11, she told people with kiddos to turn off their televisions because every time they would see horrible scenes from one of the crash sites or people jumping from buildings, the kids think it's happening over and over again in reality. And now that we have 24/7 CNN and Fox News and all of those channels, you can watch these horror things. And if your mind has a tendency to distort things, that's very unhelpful. This story was one of those literal things again, like the shells cracking. The complaint was that the woman, as she rounded this corner, this is a staff member, but as a patient in question rounded the corner, she would often take one or both of these hats and put them on her head. Now, don't you just want to ask who's more demented, the patient or the decorator trying to save a few bucks? Hats go on your head. So there you go. This one is a literal thing again. He would take the picture. This is a Texas mandated sign for body mechanics, for the people who work there to lift and move their patients safely. Lift with care, and this gentleman would, ever so easy with it, put it right down on the floor at least twice a day. This gets better. This is my favorite. A gentleman was having lunch in the cafeteria to the right, to your right in that slide. On his way back to his room, he stopped at the service entrance into the kitchen. Can you see the wet floor caution sign there? They've put it out because they've mopped it. He looked at it the longest time, and then he did. I don't make this stuff up. So this kind of thing is a literal nightmare, and these people we think are trying to escape from care facilities and assisted living, they're just following directions, Yeah, big problem. So I want to talk about the energy thing some with caregivers. 24/7 is not a plan if you're on duty for years, 3 shifts a day with somebody who has Parkinson's disease. Sleep deprivation is dangerous. Beware of any job bigger than the worker. I see these little tiny women taking care of men who weigh 50 pounds more than they do. Just because you can do something doesn't mean you should do it. If you get ill or injured, your person with Parkinson's disease is kind of out of luck many times for caregiving at a comparable level that they're comfortable with. So I spend a good deal of my professional time in senior health solutions nagging family caregivers to put themselves in the mix of who they take care of. Let me look at time here for a minute. We're pretty good. All right. In the Allied Team Training Program, we train teams of healthcare professionals, physicians, nurses, social workers, PT, OT, and speech, and music therapists, courtesy of the federal government, wanted music therapy thrown in, to take care of families in an interdisciplinary team format with Parkinson's disease. And the music therapists have taught me a lot about the fact that melody reinforces message. That's why you can remember who you were dating when Peggy Lou, Peggy Sue, or whatever was the song of the time in the 60s or the 70s. So I'm going to ask you to do an experiment with me. And Andrea, when you noted my hesitation about whether or not to let this be taped, it wasn't that I have unpublished articles I don't want someone to steal. It was because of this song. But I've written this for you, and we'll go ahead and do that. I need a rhythm section. How many of you feel really good about your world, the safety of your neighborhood, how much you can relate to other human beings when you watch the late night news right before going to bed? Is that an encouraging thing to you? Okay, well, I'm going to sing a little song for you to help you remember that that's not the best habit for caregiver health. So if you will just clap with me, keep doing that when I quit. Stop watching the news. It's making you sad. The world's a scary place. And worse, the news is all bad. Give up remote control. Take back your life, your soul. Turn off the tube. Stop watching the news. Okay, all right. When I first started at college, I was a music major, and you see why I had to divert into healthcare. Yeah, so anyway. All right. So how do you what's the nitty-gritty of taking care of yourselves as a caregiver? I start out with real basic stuff. If you're under 75, are you taking the aspirin, baby aspirin every night to prevent heart attack and stroke? Are you doing that simple, cheap thing for yourself? Do you know how important hydration is? Everybody in this room has a tendency, if you're over the age of about 60, to buy the pills, take the pills, swallow the pills, and then not drink enough water to get maximum absorption for that. So that is critically important for so many different things. Are you taking care of your own nutrition and supplements? Exercise is cheap therapy, and we're talking a lot about that today with minimal side effects. Are you diligent about taking your own medications? You make a career out of monitoring the Parkinson medications for your loved one. Are you as good remembering to take your blood pressure pill every morning? Have you had the mammogram? I talked to a patient the other day, 73 years old, and she's never had a colonoscopy, and she has great insurance. It's just between her distaste for the notion and sometimes caregiving is a wonderful excuse, for things we kind of don't want to do anyway, like going to the dentist and colonoscopies. What about the vaccines? Are you up to date on your vaccines? Is everybody getting a flu shot this year? Okay, if you haven't, by about the middle of November, waiting a little later gives you peak protection during peak flu season. So that's usually when I like to coach people to do that. But those sorts of things are important. The shingles vaccine has been out now for 3 or 4 years. If you've ever known an older adult that develops herpes zoster, like the chickenpox virus running amok later as shingles, it can be a lifetime pain sentence. It's a horrible thing that now we have a way to prevent. So mostly, I would just encourage you to take care of yourself. Make sure you're drinking enough water. It has to be throughout the day. Do the little things that are, again, cheap and effective. Use the dishpan to get the Epsom salts, hot soaks, and put your feet in it once in a while. Really take care of yourself with these little things. I encourage people to write their own job description, and I'm going to put out a plug for a book here. I think they're giving some of these away as door prizes. This is Maria Meyer's book, and I wrote the Parkinson chapter for it, but Maria and Paula Durr started doing this book called Comfort of Home, a few years ago. This is the Parkinson edition, but if you are taking care of somebody with more than just a touch of Parkinson's disease, where you're actually having to do some physical things, this is almost like, it's less about emotional coping and more almost like a nurse's aid training manual. So you can look at the review copy up here or take one of the bookmarks that I have if you want to look into that. It's a very good resource for you, and I think they're about $14 now on Amazon, so it's not a big chunk of money if you need help in that kind of regard. You have to write down, here's what I can do as a caregiver, and here's what maybe I can't. Respite, more important than recreation. You need to get away from that person sometimes. Cocktail hour is not a strategy. Maintain your own, it is a luxury sometimes, but not a strategy. Maintaining your own physical health, we've talked about. Sometimes I'm counseling people to consider having separate bedrooms. If you're the one waking up with a black eye because of a restless sleeper, I mean, you can cuddle and spend time together and then go, I mean, you can have his and hers bedrooms and just discuss your place or mine, when you want to be together. And to a lot of people, that's kind of distasteful. It's sort of like, I didn't marry up to sleep in a separate bed. But if you're going to sustain things, for the rest of your life, sometimes it's the best option. Then I often ask people, are you saving for a rainy day outside? Rainy day when it's pouring outside. We have people, really old folks, who can actually remember the Depression. They're the ones still washing off the pieces of tin foil so they can reuse it. I see that some of you are not. You just think that's responsible reuse. But those folks, and then people who are actually worried about outliving their money, those are legitimate things. There are an awful lot of people that have fair resources, though, and guess why they're not spending any money to have someone mow the yard or clean the house? They want to leave it to their kids. Yeah, now let's think about that a minute. Most of those kids are going to blow through that money within 6 months. So go ahead and hire somebody to do the yard. Yeah. I encourage people to widen their circle of support, get some people who really understand the predicament you're in. There are some good clues for that in your handouts in the packet, which you're welcome to look at later. So you need a support group for yourself. Maybe not this one, but you need 3 or 4 people in different arenas of your life who really understand what you're going through and can lend a listening ear when you need one, and who may have a more objective point of view. When you're feeling like you're just between a rock and a hard place, they may be able to think of alternatives without paying $120 an hour to see a shrink. So everybody needs that board of directors. I want to talk about advanced disease just a little bit. How do you know when things are getting more so and could get very difficult at any time so that you can begin planning for that? Changing fall patterns. Not necessarily that people fall more often, but the way they fall. Maybe they've always tended to go backward, and now they're listing to one side as they walk. Pay attention. Recurring bouts of dehydration, particularly if it requires IV water, IV therapy. More problems with swallowing, aspiration pneumonia, inability to maintain weight. By the time you get down low enough in weight that you don't have a good fat layer, I'm personally not at risk of that, but if that is happening with you, then you can't fight off infections adequately. So that's a clue. It also affects skin beginning to break down. Increased hospitalizations are a clue to worsening Parkinson's disease. Apathy to normal activities and preferences, the things they used to like to do, not so much anymore. And I want to put in a word about that. Over at Alex's I should be on commission for all these projects today, but at Alex's table with Medtronic, he is working with us in the Parkinson Alliance on surveys, quality of life surveys with controls who have Parkinson's but have not had DBS, and people over time who have had DBS, and how various aspects of their lives are. The gait and balance one and the sleep one, the voice one have already been completed. But Laura Marsh, she's a psychiatrist that was head of the Parkinson division at Johns Hopkins for many years. She was the point person on developing this latest survey on apathy and fatigue. So particularly if you have had DBS, would you pick one of those up and you just fill it out at your leisure? It doesn't have to be today. There's a self-paid envelope to go put it back in. So that would be really helpful. We always have more controls completed than we do folks who've had the surgery. And it's confidential, so it's not like somebody's going to call you to sell you a second DBS or something. So I think that's the last of my plugs. And then worsening dementia. That's a clue many times to advancing stage Parkinson's disease. I always enjoyed Walter Cronkite's quote, "After age 70, your warranty is up." And you could begin to have parts failures at any time. So we really coach people to make sure all these business things and the planning documents are in place. It's just like if you write a will, it doesn't make you die. It's just getting everything in place so it frees you up to enjoy the rest of your life. It's okay to plan for sole survivorship. One of you, if you're in a couple, is going to outlive the other. Never take for granted that it's the caregiver. You need to plan for both eventualities of what if, what would happen if, how would somebody manage if, Now, if you get run over by the same train, that you can go as a package deal, but for the most part, you need to be planning for sole survivorship. Advanced directives are best done in advance. That's why they're called that. I'll share a program with you here. And you need to do it not in a vacuum. Talk to the people you're thinking about appointing to make these decisions for you to make sure they're game. Advanced directives, you designate a surrogate for health care and life support decisions. DNR, or I love it, some states now are calling, instead of do not resuscitate, you're signing a paper that you prefer to allow natural death, the AND designation. I know Hawaii's doing that, and I've forgotten where else. But be specific in your directives. Sign and post separate transport documents somewhere easy to grab. I have one lady who lives in assisted living. She keeps hers on the refrigerator, but then she says, I get so depressed looking at that thing 2 or 3 times a day. So maybe not on the front door or the refrigerator. But if you don't know this, many 911 ambulance services are required to resuscitate you if things go bad on the way, regardless of the fact that they would have honored it at the hospital. There is a program that you might just scratch a note about this because I don't think it's in your handouts. The website is agingwithdignity.org. Just all the words run together, agingwithdignity.org. This is the 5 Wishes program out of Florida. It's legal now in 38 states, and I apologize, I did not get a chance to check on Virginia and Maryland while I was looking at this. But order those. The documents are free. They're a little cumbersome to actually have on file, with your personal wishes because it's several pages, but it is something to help you start thinking about the advanced directives questions and what you would like or not prefer to use. And then to actually, in terms of the forms you actually fill out to be official, if you don't travel a lot and there is one hospital system that you are most likely to be in if you become injured or critically ill, go to their discharge section or even admissions and ask for their paperwork, because it's usually very simple, very straightforward. You notarize it, you file it in your home county, and then that's taken care of. And your doctors at that hospital and the emergency room staff, they're accustomed to looking at their own local paperwork. So and there's no money involved. You don't need to pay a lawyer to do that. So it's a very simple way to take care of that part of business. So if you're a caregiver and you feel like you're just hanging on for dear life, we encourage you to do a careful analysis, ruthless is the word on the slide, of what you can and can't do. And go ahead and research what regional choices in other care is for you and your loved one. It doesn't mean you have, just because you go have their free lunch and tour, doesn't mean you have to sign a contract to move Bubba in, So it's not that kind of thing. It's okay to look at the options. And I'm going to skip over some of these in the interest of time. The alternatives to home care and issues with assisted living are in your handouts. And I will be here for the rest of the day. So if some of you have questions about that, let's work on that one-to-one. The pivotal challenge, scope down to the bottom of this slide. My occupational therapists that work with me on allied team training have taught me this. The most difficult challenge in late-stage Parkinson care is that the person's perception has not caught up to their actual frailty. He doesn't know he has no business on the ladder anymore. They don't realize that they need to use the cane at the house just like they do when they're out. We keep on thinking we can do what we, who's that funny hit comedian? Jeff Foxworthy says, but I used to could. But now sometimes you used to could and you can't now. So that acknowledgement is very difficult for people, and if we could get that message home, we could prevent 1/3 to 1/2 of the falls that happen. If you don't know this, 90% of falls happen at the house, bathroom and kitchen. Bathroom's a particular culprit. So what about for yourself again, caregivers? I urge people to take 1 hour a day to have totally to themselves. If you have to lock yourself in the bathroom, okie dokie. 1 day out per week. And have a wonderful family I love. He has Parkinson's, and he does not like going to the Adult Day Activity Center in Houston because he says they're all kind of nuts. And that could be true, by the way, at this place. And he doesn't have any cognitive issues much, But he goes anyway so that she can stay by herself and just enjoy some private time at their house, without being worried about him. So he does it anyway. That's his contribution to her. He also is very good at thinking, well, how can I give back? He does neck and foot massages. And I think it works out great for her. He has a lot of tremor. So I'm thinking that could be good, I don't know where you're going in your mind there, but it's just the neck and the feet. All right. Yeah. Are we about 10 minutes?
15.
Okay. All right. We'll be good. And then here's the hard sell. The one long weekend per month. People will really say, I don't have anybody who can stay with my spouse for a 3-day weekend. And that's compounded by the fact that in this economy, used to, I could say to people, just go hole up at the Sheraton in Dallas, and have a nice dinner, rent a movie, just do that. Well, now that's $200 they don't have, So that's a difficult one, but if you're going to be taking care of someone with advanced Parkinson's for several years and you're the primary person on duty, that can be invaluable. You also have to define what you mean by away. Turn off your phone. Otherwise, whoever is subbing for you will call wanting to know, where is his red shirt? And you don't care. For this 48 hours, you don't care. They'll figure it out, But that's hard for people to do, to take themselves off of 24/7 duty. So to do this, you have to build a B team, asking yourself, who in your circle is willing and capable? And actually, willing's the only one that matters, because you can teach a person the minimum skill set needed to fill in for you. They won't do it the way you would do it, but they can keep the train from going off the track. Ask for specific dates and tasks. There are some examples of that in your handout materials. Don't just say, let me know if I can do something, or I'll call you if we're in trouble, and then you just never do. You need to say, can you come pick him up to take him to the barber and have lunch next week? He would love it, to have a guy's day out for a couple of hours. Enlist the support of your care recipient, like the examples I was just giving you. That's one of the ways you people with Parkinson's can be generous and supportive and appreciative of your caregiver. Sometimes that's so hard to do because people resent needing the help. We don't like it that somebody's having to help us dress or helping us get off the toilet. And that irritation and disappointment in ourselves communicates as critique of the helper. So you really have to shift your thinking if you're the one needing help. And I'm not suggesting it's easy. I want to talk to those of you who have or are long-distance caregivers. If you can be the one, it's always interesting to me, I'll say this, I do family care conferences. And so people come in that are interested in the welfare of the person with Parkinson's disease. And it's a curious reality that many times the sibling who is the most sure of what we have to do is the one who lives the farthest away geographically. You ever notice that? And we still have families, a lot of places in the country where there are gender biases. So the son is holding the purse strings decision and the daughter's got custody of the folks. And that's not a pretty reality either. So you have to negotiate some of those things. But if you are the long-distance caregiver, this slide suggests some things that you can do. If you just see mom and dad for this long on a weekend or a holiday, they're putting on their best face for you, and they can fake it pretty good for 48 hours. You need to go stay for longer, or go and offer to be that respite caregiver for your sibling or your mom or dad who is worn out and needs that 4-day weekend. So just say yes. Dreaded duty often brings unexpected rewards. I just hear that so many times. I didn't want to go. I didn't have the money to go. I've never gotten along that well with my mom, whatever it is. But offer, insist, get on the plane. This is a note to guys. Get on the plane yourself. I don't care how much they like their daughter-in-law. You're the one, and they really want that relationship with the person who is their kid when we're talking about the generation differences. Call on the phone when a conversation is possible. And I know all the things that makes that sometimes difficult. The dysarthria, if they're living in a care facility, sometimes there is not a phone right in the room. It just can be difficult, but people love hearing your voice. If that's not possible, send cards or send flowers. My dad used to brag. He was in a nursing home the last year of his life. He had Parkinson's. And, I'm the frontline caregiver, and I'm sort of knocking myself out to do a good job of that for several years. But the happiest time in his month was always the card that would come from my brother in New Orleans. Now, I found that a little irritating, but sibling rivalry being what it is, I'm not sure, I hate to challenge the Bible, but where the love of money is the root of all evil, I think it might be sibling rivalry, actually. But nevertheless, those cards would be lined up on the windowsill. It was a treasure, and he would relook at them. Email is better than nothing, but not much. So try to remember that you, too, can afford the occasional Hallmark. I think people sometimes out of town feel so helpless and maybe guilty about not pitching in more that they just tend to do nothing. And if you live far away, you can kind of pretend like it isn't as bad, So to try to avoid that don't ask, don't tell policy is helpful. Offer to pay for something. I have so many seniors that are really strapped right now. We just learned that one more year there's no Medicare, Social Security cost of living adjustment. So that's not going to get better for a lot of our mid-level financially managed and lower financially managed seniors. So offer to pay the phone bill. Offer to pay for some dental work. Very few older adults have dental insurance. And then do it. Don't just offer. Make sure you send the money or have the bill sent to you, or it makes things worse. Show appreciation for that primary caregiver. If you think your sister's doing a great job of taking care of mom and dad, you cannot tell her that often enough. And I had a question from an audience like this last week that said, well, what if they're not doing that good a job? You lie to them. The truth is overrated in these situations. Unless somebody is in danger of physical harm, you're only allowed one good idea a year as an outsider, not one great plan every time you call home. So modify your thinking in that regard. Show appreciation for the frontline people in those jobs. So who copes best? Those folks who can adapt to a new normal as things change. Those of you who can avoid self-medicating. That gin and tonic habit does not serve us that well. People of faith, and I define that very broadly. I'm not talking about whoever's at the church twice on Sundays, but people who feel that connectedness to a God or a larger universe in whatever form it takes. Those with a really good support system. There was a study out of Wisconsin in sociology that's just hysterical. The older women who lived alone, two groups did very well. One had 4 supportive people in their life. The others had 2 supportive people and a lap dog. Are you paying attention? So, I had a dog like that once. It was worth at least 2 of the people in the family in question. So, so I didn't question it, but I thought it was a strange bit of alleged social science research. Those who have just enough money, there was a wonderful study in Forbes not long ago, or an article in Forbes, that surveys show that people need about $75,000 a year of income to really be comfortable with their level of living and their level of happiness related to things and stuff by their own report. People didn't get happier if they made twice that much. Life gets harder when you make half that much. But that was very fascinating to me. Just enough money. And people with a highly developed sense of humor. Irma Bombeck, when I was out in Phoenix, did a training for those of us who were speakers on recognizing humor. And this is still my favorite story after all these years, so I'll do it. Hopefully we have mostly new audiences. Irma said that being a good sense of humor is not about being a comedian. It is recognizing what's funny. How many of you think you're good at that? You recognize what's funny around you. Pretty good. Maybe half or more. Some of you seem to have some challenges, so I'm going to offer you a challenge. When you get home, and please do this alone so you won't frighten anyone. I need another sip of water. I want you to stand in front of a full-length mirror with your watch on and take off all of your clothes. Don't panic. This is as far as I'm going. And if you don't see anything funny in 5 minutes, I want you to call Miriam Hirsch and see if she can find you a remedial humor recognition course, because you need some help, you know? You need help, yeah. It will work for you. You will see something funny, head to toe, I promise you. So in closing, I would share that as you're learning to live and adapt over the years to a health condition like Parkinson's disease sort of intruding and then incorporating into your life, I would urge you to stay flexible, to be willing to try some new things from time to time that maybe you haven't thought about in the past, and most of all, to never give up hope. My favorite poem is Emily Dickinson's that the first stanza reads, "Hope is the thing with feathers that perches in the soul and sings the tune without the words and never stops at all." Thank you.